Okay, good morning everybody, and I want to start by thanking the organizers for the opportunity to speak today on some of our programs. Thanks, Mano, for the history lesson. I never knew that about King George. Very interesting. Now I know why he was crazy. I didn't see that in Hamilton, but the organizers, not you, Michelle, or you, gave me an odd title. I was very pleased with the opportunity to speak, but they said, we want you to speak about non-liver targets. I didn't know exactly why, but I'm happy to do that. And they did say plural, so I will abide by my instructions and follow through and not focus on liver targets. Okay. I'm holding. Good. So antisense oligonucleotides, I think you're all familiar with the mechanism of action. What we're doing with antisense, of course, is targeting RNA with single-stranded oligonucleotides that generally do not require any sort of nanoparticle formulation or delivery vehicle to distribute broadly and penetrate cells and bind to the RNA and exhibit its effects. Antisense oligonucleotides also have the opportunity to both upregulate gene expression for loss-of-function diseases as well as downregulate gene expression for gain-of-toxic function diseases. You heard from Claudia this morning about Spinraza, which is an example of upregulation of a lacking protein, and there are also many examples of reducing protein production, such as for Tegsedi, for the treatment of hereditary TTR amyloidosis with polyneuropathy. Now, one of the aspects of the technology that we've perfected over the years at Ionis has been the efficiency of the technology and also optimizing the way we apply the technology and understanding what are the most sensitive tissues and cell types. And that has resulted in a very broad, deep, and expansive therapeutic pipeline covering many different therapeutic areas and also many stages of development, including commercialization of a number of products, phase 3 programs, and so the like. Now, going back to the title request that I had, we do have about 2/3 of our pipeline is focused on liver targets. Now, that doesn't mean we're working on liver diseases. As Mano showed you for TTR amyloidosis, most of these targets are actually produced in the liver, but they cause all kinds of different types of diseases, such as age-related macular degeneration, or amyloidosis, or thrombosis, and those sorts of things. Nevertheless, I understand why I was asked to do this, because the technology is so versatile and we can do a lot more outside the liver. I did want to leave you with a couple of things that I will not be talking about with respect to the liver, and that is Tegsedi for the same disease indication that Mano just talked about for the treatment of hereditary TTR amyloidosis, which was the first RNA-targeted medicine approved for this disease. Waylivra for familial chylomicronemia, which has a CHMP positive opinion, and we're expecting approval imminently for that disease in Europe, and a whole host of other liver targets for diseases such as rare diseases like beta thalassemias, and also common diseases like cardiovascular disease due to lipoprotein(a) expression or thrombosis. But I do understand, as I mentioned, why I was asked to speak about non-liver targets. The technology is incredibly versatile, and we've optimized it for all kinds of different therapeutic opportunities over the decades we've been developing this technology. We've demonstrated that we can deliver these molecules systemically through subcutaneous administration or intravenous, of course, and also we pioneered the delivery of other routes of delivery, such as intrathecal delivery that you heard about from Claudia this morning for its neurodegenerative diseases, and we've optimized it. Inhalation for pulmonary diseases, as well as intraocular delivery for eye diseases as well. And we've shown clinical efficacy in many of these tissues for different types of targets as well. What I want to focus on initially is neurological diseases. So we're going to go back to neurology. And what I want to point out is what our sort of strategic approach was to developing a neurological platform. 10 years ago, when we first started this, antisense oligonucleotides do not cross the blood-brain barrier. So we asked ourselves, what can we do to deliver these molecules to the CNS, and will they be effective? What we did was start to explore intrathecal delivery, and we asked, and we set out on a strategic approach in which we first started by focusing, of course, on undruggable targets that have been linked to human diseases. Can we target these types of genes, gene products that cause diseases? Can we demonstrate, and we have, broad distribution of antisense oligonucleotides following intrathecal delivery in the CNS? And we've shown now activity in all brain regions, as well as the spinal cord, as well as the deep brain structures, and all cell types in the brain have been also demonstrated as well, such as neurons, astrocytes, and so on. We've shown that these effects are durable, allowing us to dose intrathecally once every few months. And the safety and tolerability profile in the CNS, as exemplified by Claudia, has been excellent to date. And we're continuing to optimize the technology for neurodegenerative diseases. Spinraza, you've heard about this morning. It's a miracle drug. It's a breakthrough for spinal muscular atrophy, all forms of spinal muscular atrophy. And Spinraza, of course, was discovered and developed initially at Ionis Pharmaceuticals and then partnered with Biogen. Biogen has continued the development of the medicine and has commercialized the drug and has been very successful in launching it in over 40 countries to date. Most of the patients that are pediatric and infants with SMA in the United States are actually on Spinraza, and there's a growing penetrance into the adult population with Spinraza as well. So it's a real breakthrough. Claudia already talked a little bit about the pre-symptomatic patients, the NURTURE study, in which pre-symptomatic SMA type 1 babies were getting treated with Spinraza, and the majority of these patients are actually developing normally, which is a real breakthrough. And also the SHINE study being conducted by Biogen, in which they're studying the long-term treatment of Spinraza in patients, has shown that these patients with SMA are actually continuing to improve over time, not just stabilizing, but continuing to improve over time with up to 6 years of data demonstrating this improvement with excellent safety and tolerability. So Spinraza was the first of our medicines to move into neurological diseases. Now I'd like to move on to one of our most advanced programs in the pipeline, which is our medicine for Huntington's disease. We heard this morning about Huntington's disease, so I don't need to dwell on this too much. It's a fatal neurological disease caused by mutations in the Huntington gene. So the cause of the gene is well understood. It's a non-druggable target. The mutation is due to expansion of the CAG elements in the Huntington gene, causing repeats of more than 35 or so. It's hereditary. It's passed down from generation to generation. It's devastating. It's fatal. And there are no treatments for this horrible disease. What we've shown with our lead drug for Huntington's disease, Ionis HTT-RX, or now RG6042, is that we can produce robust reductions of the mutant Huntington protein in the cerebral spinal fluid in patients that have symptoms of Huntington's disease in a phase 1/2 study. We've shown that we've provided some evidence correlating the reductions in mutant Huntington protein with improvements in motor function in these patients in this short phase 1/2 study, and I'll talk about that a little bit in a moment, with excellent safety and tolerability. And now, based on this data, we've partnered the program with Roche, and they actually have now launched a phase 3 pivotal study to bring this medicine to patients as rapidly as possible. This slide shows the design of the phase 1/2 study, the first in-human study with Ionis HTT-RX. This was a dose escalation study, looking at doses ranging from 10 milligrams monthly to 120 milligrams monthly. It was only a 3-month study, and these were patients that had just experienced initial symptoms of Huntington's disease. And as you may or may not know, Huntington's disease progresses relatively slowly in the early stages of disease, and then it's like falling off a cliff in which you really fall to the disease. The primary objectives of this study were to assess safety and tolerability, since it was a first-in-man study, but then also secondary objectives, very importantly, was to look at Huntington protein levels, reductions in HTT levels in the cerebral spinal fluid. Us, Ionis, and Roche actually spent a lot of time developing assays to measure mutant Huntington in the CSF, but not only that, to correlate those reductions to what was happening in the CNS, in the brain, and to assess and to determine what levels of reduction got us into the pharmacologically effective range based on preclinical data. So we actually had excellent extrapolation from CSF to CNS. This slide shows the reductions, the dose-dependent reductions in the mutant Huntington protein on the left at the 3-month time point in the study. What you can see are very dramatic dose-dependent reductions of the mutant Huntington protein that maxes out at around 90 milligrams per month. Again, this is only three months of treatment. And on the right, in the continuation of treatment, the extension of this study, you can see that the mutant Huntington protein levels are continuing to go down beyond 90 days. So we didn't even reach steady state at 3 months, yet we were getting excellent, robust reductions of the mutant Huntington protein. So the reductions in mutant Huntington protein are robust, and it was well tolerated and safe in that phase 1/2 study. This led to the launching of a pivotal phase 3 study by Roche, as I mentioned. This is a very comprehensive study. The key inclusion criteria are shown on the left. It's a much broader population of Huntington patients than what we tested in the phase 1/2 study. The sample size is targeted to be 660 patients, and there are 3 dosing cohorts. One dosing cohort will be dosed intrathecally every 2 months, every 8 weeks. A second dosing cohort will be dosed every 16 weeks. This again owing to the durability of the antisense activity in the CNS. And then there will be a placebo group. The study is targeted to roll out for 25 months, after which all patients will be allowed to be eligible for an open-label extension study. The primary endpoints have been obviously agreed to by regulatory authorities, and the study is underway. Roche is actually committed to bringing this medicine to patients as rapidly as possible by developing a comprehensive program to develop this medicine for Huntington's disease. The phase 1/2 study that I referred to earlier, that I described earlier, has now moved into the open-label extension phase, in which patients in that study are all continuing to be treated over now multiple years with this medicine, and we're following the course of those patients now. Roche has also initiated a natural history study that includes patients that resemble that of the phase 1/2 study. So this natural history cohort is essentially serving as a control group for the open label extension patients that are being treated to study how the drug is performing. I already talked about Generation HD1, the phase 3 study, and then Roche has also launched planning to launch a new study correlating the reductions of Huntington protein specifically with disease outcome called Gen-Peak. So this has the potential to be another breakthrough for neurological diseases targeting Huntington protein. I covered all these topics. Just want to emphasize the point that Roche has made on multiple occasions that they're going to do everything they can to bring this medicine to patients as rapidly as possible. So stay tuned. Now I'd like to move on to another neurodegenerative disease that has tremendous unmet medical need. Amyotrophic lateral sclerosis, or Lou Gehrig's disease. ALS is a fatal disease. It's an orphan disease with obviously a high unmet medical need. Patients become paralyzed. It's different than Huntington's disease. Huntington's affects the cognitive ability, psychiatric, as well as motor function of an individual. These patients are actually trapped within their body. They become paralyzed, but their cognitive function is essentially normal. Patients usually die of this disease within a few years after symptom onset. So it's actually a much faster progression of disease than in Huntington's disease. More recently, different causes of ALS are becoming better understood. It's clear that there are genetic forms of ALS today, as well as what we call sporadic forms of ALS, non-genetic forms, or at least causes of the disease that are not yet well understood. Two particular genetic causes of ALS are due to gain of toxic function of the SOD1 gene, superoxide dismutase, as well as C9orf. These are two examples of genetic causes of ALS. We're attacking ALS comprehensively. Our first program to target ALS is targeting SOD1 related ALS. Mutant SOD1 has been known to cause ALS since 1993. That's how long it's been, and yet no therapies are available to treat SOD1 ALS, actually any form of ALS in any meaningful way. It causes 15 to 20% of genetic causes of ALS are due to SOD1 mutations. It's due to the misfolding of the protein, aggregate formation, and then toxicity to neurons and other related cells. It is not due to mutation. It is not due to effects on the enzymatic activity of SOD1. So small molecules that inhibit the enzyme activity of SOD1 are are without any efficacy. It's due to the aggregate formation. So what we want to do here is knock down the toxic function to treat ALS. We, with our partners Biogen, have now completed a phase 1/2 study designed very similarly to that of the Huntington phase 1/2 study, a 3-month study in symptomatic patients with SOD1 related ALS, dosed intrathecally with our SOD1 ASO once a month. And again, since it's a first-in-human study, the objective was to show safety and efficacy. And then secondarily, based on the fact that we also developed assays for SOD1 in the CSF and correlated those reductions to what was happening in the brain stem, in the spinal cord, we can extrapolate the reductions in SOD1 in the CSF to what was happening in the CNS. And that was a secondary objective too, as well. And of course, there were also exploratory changes in SOD1 protein, exploratory changes in looking at function in these patients, looking at ALS, ALS functional rating scale, which is a well-accepted rating scale for measuring the progression of disease in ALS. This drug is now referred to as tofersen. The phase 1/2 results have demonstrated both proof of biology, that is reductions in SOD1, and proof of concept, that is strong trends in disease improvement, or at least stabilization of disease progression. Treatment over a 3-month period has resulted in statistically significant lowering of the SOD1 protein levels in the CSF, and also a stabilization in the clinical decline as measured by the ALS functional rating scale. The numbers are shown there. Biogen put out those numbers yesterday in a press release, and this data will be presented at the AAN meeting in much more detail next week by Dr. Timothy Miller from Washington University. Based on this data, Biogen has now launched this program into phase 3 development for SOD1 ALS, and that study is now off and running. This has received a lot of attention. Actually, just yesterday, this is the news that came out. I don't know if this is a Fox crowd or a CNN crowd, but this has to make your heart warm, the fact that there now appears to be, potentially for the first time, a potential treatment for a form of ALS, a disease that really has had no treatments to date. This came out yesterday evening, and I just wanted to share it with you. So based on this phase 1/2 data, Biogen has launched the VALOR phase 3 study, and they've done this in a very efficient way, a way to bring this medicine to potential regulatory approval as fast as possible. And what they did was simply add an additional cohort to the ongoing phase 1/2 study, the 100 milligram dose cohort, cohort 5, shown in the gray area is the phase 1/2 study. What they simply did was added more patients to the 100 milligram group and controlled it with placebo. Now the primary endpoints, of course, are function, ALS rating scale, safety and tolerability, and they'll continue to monitor SOD1 reductions. So we and Biogen are committed to ALS. SOD1 is our first medicine moving forward for the treatment of a genetic form of ALS. We also have a phase 1/2 study to target C9orf, a more common genetic form cause of ALS, genetic cause of ALS. That data is, the design of that study is very similar to what I showed you for SOD1, and data is expected from that study early next year. In addition, we're working hard on sporadic forms of ALS, and those programs should be reaching development in the future. So in the last few minutes of my presentation, I want to change gears really significantly. Now I want to talk about oncology. I want to talk a little bit about cancer, and I have to start with chemistry. And as Mano said, you know, when you are presented with a problem, don't panic, just do chemistry. And that's what we've done for cancer at Ionis, where we have shown over the years that we can get activity with earlier generation chemistries in cancer, but it wasn't good enough. We needed better potency. And what I want to mention here to start with is that the chemistries I've talked about to date, so far, in the neurological platform, are second-generation chemistries, 2'-methoxyethyl chemistries, 2'-mo chemistries. And these chemistries have done okay in cancer, but not good enough. More recently, we've developed a chemistry called Generation 2.5, a constrained ethyl, or C-et chemistry, which has improved potency and has allowed us to penetrate tissues, cell types that are less sensitive to antisense, such as skeletal muscle or cardiac muscle, and very importantly, tumor cells. Our lead generation 2.5 molecule and our lead oncology molecule targets STAT3. It's called danvatirsen, and this drug is now in phase 2 development. STAT3 is a very interesting cancer target because it plays a significant role in tumor cells directly as an anti-apoptotic protein, as well as an as well as a pro-proliferative protein in cancer cells. But more than that, STAT3 plays a very important role in the tumor microenvironment. STAT3 has been shown to be immunosuppressive in the tumor microenvironment, blocking the host's ability to eradicate itself of cancer cells. In addition, STAT3 has been shown to block the activity of immuno-oncology agents such as checkpoint inhibitors, such as PD-1 inhibitors and PD-L1 inhibitors. So it seemed like an excellent target to go after for oncology for a number of different mechanisms. Danvatirsen targets STAT3. It was discovered and initially developed at Ionis and has since been licensed to AstraZeneca, which is continuing the development. As I mentioned, it's a direct tumor target as well as a target relevant to the immune cells in the tumor microenvironment. We have shown robust anti-tumor activity in a broad range of preclinical cancer models, and more importantly, we've shown anti-tumor activity in humans now, both as a monotherapy as well as in combination with checkpoint inhibitors such as the PD-L1 inhibitor durvalumab in patients with refractory head and neck cancer. This shows a comparison in a tumor xenograft model of a Gen 2 antisense oligonucleotide targeted to STAT3 versus a generation 2.5 antisense molecule targeted against STAT3. Looking at the pharmacodynamic activity in lowering STAT3 protein levels. And what you can see in the highlighted region, it's pretty obvious that the Gen 2.5 STAT3 ASO is much more effective at reducing STAT3 in tumor cells in the xenograft model, both at the protein level and on top at the RNA level. On the right just shows some PK data in tumors showing that the increased activity is not due to better uptake into the tumor cells. Notice that the doses are different. The accumulation is essentially the same. It's really due to intrinsic better potency of this chemistry against the target RNA in cells. This better potency for target reduction translates to better anti-tumor activity in a range of tumor models. This slide just shows 2 xenograft non-small cell lung cancer tumor models, PC9 and H1975, showing marked anti-tumor activity with this chemistry, with this molecule, and also reductions in STAT3, as shown on the bottom. We also explored preclinically the effects of the Gen 2.5 c-Et molecule in the tumor microenvironment and asked questions: are we targeting cells in that environment, and what cells are we targeting? And to do this, we actually looked at syngeneic models and treated with a STAT3 ASO or other ASOs against other targets, fractionated the tumor cells and the tumor associated cells and asked, are we getting target reduction in the various cell types? So we looked at cells, we looked at all tumor cells, we also looked at immune cells such as lymphocytes, CD45 positive lymphocytes, fibroblasts, myeloid-derived suppressor cells, and macrophages that are associated with the tumor. And what you can see in the green color here is that we're getting great reductions of target STAT3 in the tumor microenvironment as well as in the tumor cells. PD-L1 antibodies have shown great efficacy in tumor xenografts as well as in humans, but their efficacy is not 100%. It's sporadic at best, and that can be reflected in preclinical models. In this case, showing the activity of durvalumab in a mouse tumor model, CT26, where you can see some of the animals respond very well and other animals respond less well. But on the right, you can see what happens when we combine danvatirsen, the STAT3 antisense oligonucleotide, with the PD-L1 antibody, where you can see dramatically improved efficacy. And we've now shown this with AstraZeneca not just in the CT26 model, but also in breast tumor models, lymphoma tumor models, as well as in combination with other checkpoint inhibitors, such as CTLA-4 antibody and an OX40 antibody, in which case, shown in the green line on the bottom, is the combination effect compared to either PD-L1 antibody or STAT3 ASO alone. And what you can see is that in every case, we're getting an additive, sometimes synergistic benefit by combining a checkpoint inhibitor with the STAT3 antisense. So the first in-man study for danvatirsen was in the monotherapy study. This is now published, so I'll move quickly through it, but it's basically a dose escalation study in which all cancer patients were allowed into the study to select, the goal was to select the dose. The study was enriched with the patients with diffuse large B-cell lymphoma. We demonstrated monotherapy efficacy, again, in a number of patients. These are patients that are now refractory to any other treatment regimen that is allowed for diffuse large B-cell lymphoma or other cancers. So these are patients at the end of their line, if you will, and refractory to other agents. What we were able to show as monotherapy was multiple complete responses in diffuse large B-cell lymphoma, multiple durable partial responses in DLBCL, as well as a number of stable diseases. And we were able to show on the right anti-tumor activity in hepatocellular carcinoma, as well as in a non-cell lung carcinoma that had metastasized to the liver. Based on these data, AstraZeneca then moved, and the preclinical data I took you through, AstraZeneca moved this program into a pretty complex phase 2 study in refractory metastatic head and neck cancer, in which they looked at various combinations of danvatirsen, as well as some other medicines that they're developing, such as AZD5069, all in combination with their PD-L1 antibody, durvalumab. What I want to focus on, of course, is danvatirsen in combination with durvalumab in this patient. This data was just recently presented at ESMO. And what was demonstrated is pretty impressive anti-tumor activity with this combination in patients with refractory head and neck cancer. What we're looking at here is tumor burden over time. And what you can see is in green and blue, a number of patients that have responded completely, as well as patients that have responded quite dramatically, significant partial responses, and the responses have been quite durable. This response rate is estimated to be more than 2 times that of durvalumab alone in this patient population, based on studies that AstraZeneca did themselves. So, and in addition, based on tumor biopsies, AstraZeneca has demonstrated that danvatirsen is being taken up in the tumors, as well as they're shown reductions in STAT3. So the next steps for danvatirsen is to complete the ongoing phase 2 study, and then based on the evaluation of all the data, to move potentially to a pivotal study. And news on that will be coming out this year. And danvatirsen is also being evaluated in combination with durvalumab in a number of other cancers, and information on that will be coming out later this year. So to wrap up, Antisense, I think it's pretty clear, is now a validated platform for a broad range of indications, not just liver, but outside the liver. It's a commercial success, as well as obviously a clinical success. Many organ systems, many routes of delivery are approachable, including cancer. We can exploit different mechanisms of action, as illustrated by Spinraza versus some of the targets I went through today, which cause a reduction in target. And the technology continues to improve with new advancements in medicinal chemistry, routes of delivery, and mechanisms of action. So with that, I will take any questions, and thank you very much for your time. Yeah, it is a huge unmet medical need. Pancreatic cancer is, it is one of the cancers we're looking at in the exploratory studies that I referred to on the third to last slide. So we are looking at a number of different cancers, including pancreatic cancer. There's no data out on that yet, but based on this data, we are putting out a broad net, including pancreas.
I had a quick question on Huntington's program. I was just wondering, do you see the reduction of the wild-type Huntington as well? And also, how long, I mean, you mentioned that the phase 1 trial was 3 months that the patients were. How much longer were the patients followed, and do you continue to see improvement?
Yeah. So the drug, the medicine that I've described here is reducing both mutant and wild-type Huntington protein. The data I showed you is only mutant. The assay we use is only mutant, is an assay that only detects mutant Huntington protein. These patients have now been treated for up to nearly 2 years, and the tolerability and safety has been excellent. We've also completed long-term chronic toxicology studies in non-human primates, in which we're getting 80% or greater reductions in the CNS of Huntington, and the safety studies have been really unremarkable to date. So we're moving on to what has enabled us to move on to a pivotal study.
Thank you.
You're welcome.
All right, thank you very much again to Brett and all the speakers.